You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or, Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for August 23rd, 2024. This week, suicidal ideation and the GLP-1 drugs, a repeat of paradigm HF in Chagas cardiomyopathy, Castle HTX gets a serious critical appraisal in the journal JACC, and primary prevention of sudden cardiac death and heart failure is definitely changing. First up is suicidal ideation with GLP-1 drugs. JAMA Network Open has published a drug safety study on the GLP-1 agonist semaglutide that is making the rounds in the media. I have read the study and have one clear thing to say. Pharmacovigilance is quite complicated. Now, the top-line results found a signal, an association of semaglutide use and suicidal ideation. Now, given the many millions, soon perhaps billions of people who will take these drugs, it's really important signal to sort out, especially since increasing numbers of young people will take these drugs for potentially very long periods of time. And as much as I love RCTs, trials cannot sort such a signal out, right? A, many of the trials exclude patients who have underlying mental health disorders, and B, the numbers of patients in the trials is going to be way too small to find such a small incidence signal. So observational studies of large databases is the main way to find drug adverse effect signals. The problem, of course, is that when large databases are used to make non-random comparisons, it's hard to know if an association is causal or if it's due to the many different biases such as confounding by indication or collider bias or other biases. The authors of the JAMA Network Open paper used a massive WHO database of reported adverse drug reactions to do a case control study of semaglutide and liraglutide. Now, the indications for the drug here were diabetes, weight loss, or off-label, and this is actually a really good thing because it mirrors how the drug is being used in the real world. The database has 30 plus million adverse drug reactions, and of these, they found 107 reports of suicidal thoughts with semaglutide and 162 with liraglutide. This represented about 0.3% of the total ADRs with the drug. So right away, we see how low the incidence of this adverse drug reaction is. The authors then did something called a disproportionality analysis, and of course, I have zero experience with such a method. I read that a disproportionality analysis compares the observed proportion of an adverse event for a specific drug to its expected proportion within a given set of data. In this case, they tell us that the reported odds ratio, which is the odds that reports with a drug-drug pair record the event of interest divided by the odds for other drugs. The main finding of this paper was a significant disproportionality was detected only for semaglutide-associated suicidal ideation, and the reported odds ratio was 1.45. That was statistically significant, and it remained significant in patients who co-reported use of antidepressants or benzodiazepines. The reported odds ratio was 4 times that of DAPA, metformin, and orlistat, which are other diabetes and weight loss drugs. The same signal of increased reporting was not noted for liraglutide. Now, one strength of the study was that a D-challenge analysis found that suicidal ideation resolved after semaglutide discontinuation in 2/3 of the cases. Another strength of the study was the numerous sensitivity analyses. Here they found the same signal of 4 times the reporting odds ratio when semaglutide was co-prescribed with antidepressants and benzodiazepines. So my comments. Now, there are oodles of limitations of this study, and the authors do a great job of outlining 10 of them, and they write clearly that this association does warrant urgent clarification but does not indicate causality. Most of the limitations you have heard before. 2 biggies include A, are patients who get this drug particularly predisposed to mental health disorders, or is there something about the drug that is causing this issue? Or B, is the self-reporting data even robust enough to rely upon? Now, the authors outlined in the introduction that previous reports of suicidal adverse drug reactions with this class of medicine are unclear. One study even shows a benefit in mental health with GLP-1 drugs. And that kind of is believable, right? Because weight loss could clearly improve your outlook. But also, not being able to eat could dampen your spirit too. So I guess both possibilities are possible. I'm obviously not an expert in pharmacovigilance nor disproportionality analyses, though the authors did cite a paper that found, quote, considerable variability in disproportionality results, both positive and negative signals, could be generated for 60% of all drug event pairs, depending on the type of model used, whatever the truthfulness of the model. I take this paper, which I'll cite, to mean that there is a bunch of analytic flexibility in the disproportionality method, and that's already been shown, and I've talked about with analytic flexibility in many types of observational studies. Bottom line is, I'm not convinced that this study is strong enough to affect prescribers of this drug for its evidence-based indications, the diabetes and obesity treatment in patients with established heart disease, that is the SELECT trial indication. I would worry about it, though, for, say, a 17-year-old patient for obesity, especially if he or she was on antidepressants, because if we're giving these drugs to young people, they're going to have to be on them for a long time. I highlight this study because sorting out even low incidence adverse drug reactions in a drug that we're going to give to millions of people is obviously a vital thing to do. I'm glad people are working on this matter for GLP-1 agonist. I learned a lot from reading this paper and the citations. It's also very noteworthy that the paper is well written and easy to read. All right, second topic is the parachute heart failure trial, repeating the mistakes of paradigm HF. A Brazilian colleague alerted me to an important rationale and protocol paper published in JACC Heart Failure. The parachute HF trial will randomize about 900 patients with chronic Chagas cardiomyopathy to either sacubitril valsartan, 200 milligrams a day, or 20 milligrams of enalapril. And here we go again, another weak test of sacubitril valsartan. But first, let's say a few words about Chagas cardiomyopathy. Again, I'm not an expert. Chagas is caused by trypanosoma cruzi infection. Chagas remains a serious health problem that affects about 6 million people, mainly in Latin America, but it's spreading through the world due to migration of infected patients to North America, Europe, Asia, and Australia. Cardiomyopathy is the most serious complication of this infection, occurring in 20 to 39% of infections during long-term follow-up. The cardiomyopathy is characterized by myocarditis that can involve all areas of the heart and conduction system. I've mentioned before that Chagas has made Brazil an epicenter of VT ablation. American EP fellows learn to do PVI, and Brazilian EP fellows become expert in epicardial VT ablation. Now, VT, though, isn't the only complication of Chagas cardiomyopathy. These patients also have heart failure, and epidemiologic studies comparing Chagas to other types of non-ischemic cardiomyopathy find that Chagas confers higher rates of death, heart failure hospitalizations, and worse scores on KCCQ questionnaires. Basically, Chagas is a bad cardiomyopathy. Parachute is a Novartis-sponsored trial that will test sacubitril valsartan versus standard ACE inhibitor enalapril, and I think this is sad. Sad because here we have another chance to put sacubitril/valsartan to a proper test. It boggles my mind that we simply don't test sacubitril/valsartan to valsartan alone at the same dosage. That would isolate the effects of sacubitril and the question would be answered, period, end of story. Instead, Parachute, like Paradigm, tests a higher dose of sacubitril/valsartan versus a medium dose of enalapril. In other words, the degree of RAS inhibition is going to be different, less with enalapril. If sacubitril/valsartan wins in Parachute, we won't know if it is the sacubitril or the higher dose of RAS inhibition. This was the main issue with Paradigm HF. Now, the other issue with Parachute is the primary endpoint. Instead of looking at the standard endpoints of CV death and first heart failure hospitalization, the authors also add change in NT-proBNP at 12 weeks. And now that's going to be added into a hierarchical primary endpoint, and it's going to be analyzed by a win ratio where, of course, CV death is the most important, then heart failure hospitalizations, then BNP. The author's reasoning for using lower doses of enalapril is that this is the dose that was used in previous clinical trials, specifically the SOLVED trials, which used 10 milligrams BID. They write in the rationale paper that there is low-quality evidence that higher doses of enalapril improve efficacy. Here they cite the consensus trial, which targeted 40 milligrams daily of enalapril, but only achieved a mean dose of 18 milligrams per day. This argument, my Brazilian colleagues tell me, is misleading because consensus studied class 4 heart failure patients and Parachute will enroll class 2 to 3 patients. Of course, a class 4 patient is less likely to achieve target doses or high doses of enalapril because they have class 4 heart failure. Now, I know that there are heart failure experts who disagree with my criticism of Paradigm dosing of enalapril, but there is a meta-analysis from heart failure key opinion leaders, first author, Dr. Mohammed Khan. It's published in Circ Heart Failure. I'll cite it in the show notes. This meta-analysis looks at RCTs of ACE and ARBs in HFrEF, showing that higher versus lower doses of RAS inhibition decrease mortality and heart failure hospitalizations. The meta-analysis also notes similar discontinuation rates of higher and lower doses. So there you have it. Key opinion leaders showing that higher doses of RAS inhibition is actually beneficial. Now, my Brazilian friends also pointed me to another more recent meta-analysis, the first author, Joseph Rindone, and I'll cite this paper, looking at how sacubitril/valsartan compares to equivalent and subequivalent ARB or ACE inhibitors in patients with HFrEF. The European Journal of Pharmacology published this study, and they had 12 trials in this meta-analysis, and get this, there were no statistical differences regarding the outcomes of mortality, cardiovascular mortality, and worsening heart failure in the equivalent dosing group. However, the meta-analysis authors found that sacubitril/valsartan reduced total mortality, cardiovascular mortality, and worsening heart failure in the subequivalent group. All right, my comments. Sacubitril/valsartan remains one of the most costly therapies in cardiology. It's been widely accepted, it's codified in guidelines, but Paradigm HF had a serious limitation, not limited only to the dosing of RAS inhibition. Remarkably, sacubitril/valsartan effects were not confirmed when tested in a post-MI LV dysfunction cohort in the Paradise MI trial. Why? Perhaps because in Paradise MI it was tested against a higher ACE dosage of ramipril 5 BID. Now, I don't doubt the veracity of the data in Paradigm HF, but I think sacubitril/valsartan should have to pass muster against an equivalent dose of RAS inhibitor, preferably against valsartan alone at the same dose. Why has this not been done? Outside of one trial, the small LIFE trial, which actually found no benefit of sacubitril/valsartan over valsartan alone in patients with severe heart failure, that was just a pro-BNP endpoint. But why? It tempts me to be cynical about the potential for bias in research design here. bias in that since Novartis pays for these trials, we get designs that make it easier for sacubitril/valsartan to win. Parachute-HF looks to be another soft test of sacubitril/valsartan, not only against a lower dose of enalapril, but also with the added soft endpoint of BNP in a win ratio analysis. Look, I have nothing against industry. They've helped design important new therapies, but industry-based science has its flaws. Therefore, it's on us, the users of the medical evidence, to be critical appraisers of it and to be resistant to the hype that often accompany trial results. All right, speaking of critical appraisal, the next topic is the Castle-HTX trial receives a serious critical appraisal. 1 year after New England Journal of Medicine published results of the Castle-HTX trial of catheter ablation of AFib in patients with end-stage heart failure, a strongly argued critical appraisal has been published in JACC. The title is worth repeating. Here's the title. Quote, catheter ablation for atrial fibrillation and advanced heart failure. Can we trust the Castle-HTX trial? Now, before I say anything specific, let's consider how weak the journal platform is compared to social media and blogs. Christian Soames presented this trial last August at ESC, and New England Journal of Medicine published it at that time. The letters to the editors in the New England Journal came 4 months later in December. Now we get a serious critical appraisal in long form from Drs. Nathan Mutin, Florian Zeres, and Milton Packer exactly a year later. A year. Now, similar appraisals of the Castle-HTX trial were available on Twitter and blogs nearly immediately after the publication. Anyways, the gist of the matter is that Castle-HTX was a hugely positive trial. About 200 patients from a single referral center in Germany who were referred for heart transplant consideration. Patients had AFib and were considered to have end-stage heart failure and considered for transplant. One group received AF ablation, the other group medicines alone. The results were stunningly positive. 8% of those in the ablation group had a primary endpoint of death, LVAD, or urgent transplant, versus 30% in the medical therapy arm. The hazard ratio was 0.24, and the p-value was way low, and so hugely significant. This was a 76% reduction, a 70% reduction in overall death. The authors felt that this extended the results of the previous Castle-AF trial, which also found that AF ablation was superior to drugs in patients with HFrEF and AFib. Castle-AF had a 47% reduction in a composite endpoint, but the differences in Castle-AF took many months, a couple of years, to be evident. In Castle-HTX, the Kaplan-Meier curves separate immediately. Now, the authors of this critical appraisal outlined 5 big reasons to doubt the results of Castle-HTX. Their first point was that the 70% reduction in death was much larger than one would expect by the modest reduction in AF burden noted in the trial. In Castle-HTX, the AF burden ablation arm was reduced by about 30% at 1 year in the ablation arm versus 9% in the medical arm, so a positive but modest difference in AF burden reduction in the two groups. By the way, this is my main criticism of the EAST-AF trial, namely that there was very little difference in AF in the two groups, early rhythm control or standard of care, so it's hard to argue that rhythm control of AFib was responsible for the benefits in hard endpoints. The second argument of these authors was that 10 patients with end-stage heart failure were included per month in a single-center trial during the pandemic. By comparison, the Castle-AF trial only enrolled about 10% of patients in a trial with 33 centers that took years. Third point was the matter of end-stage heart failure in this trial. Most patients in Castle-HTX, they write, did not have robust evaluation for end-stage heart failure, and the 1-year mortality rate in Castle-HTX in the control arm was 15 to 20%, which is substantially lower than the accepted rate of mortality for end-stage patients, which is 50% at 1 year. The author's fourth criticism was that Castle-HTX recruited only 194 patients in an open-label study that had few events. The difference in events, 8 versus 30%, reflects an analysis of less than 40 events total. And I've heard Dr. Packer make this argument against Castle AF that because numbers are lower, small numbers mean a bigger chance of noise. Now, their fifth point was similar to their first in that at 1 year, only 5 patients in the ablation arm remained in sinus rhythm versus 1 patient in the control arm. AF ablation, they write, did not have an impressive effect on AF, so how could it drive a 70% reduction in death? Now, maybe I missed it, but to me, the biggest worry about Castle HTX is the immediate separation of the mortality curves. Like right away, it was almost as if being randomized to the ablation arm magically improved mortality. If ablation improves outcomes in heart failure patients who have AFib, it seems likely to occur by reducing AFib over time, and you'd expect to see that late, like in Castle AF. Finally, I think this trial, this Castle HTX trial, highlights the tension in my mind about the ways of knowing in medicine. On the one hand, I've always believed, and still do, that RCTs should guide what we believe, and that we need to do more RCTs. But increasingly and gradually, I've come to know the limits of RCTs, and that trials have to be done with extreme care and vigor so as to provide useful data. It's not enough to just randomize. You need a lot of thought and care in the planning and execution of trials. The Parachute and Castle HTF trials that I've just highlighted expose sort of the limits of what we can do and use from trials. Next topic and final topic, there is more data suggesting modest benefits of the primary prevention ICD in heart failure. Danish investigators, some of them my friends from Copenhagen, have published an interesting paper regarding real-world incidence and risk factors for first and recurrent shocks in patients with ICDs. The JICE, the Journal of Interventional Cardiac Electrophysiology, published their analysis. First, some background. I remember it like it was yesterday. The enthusiasm when Scud Heft and Made It To reported benefits of the primary prevention ICD. I call it the period of irrational exuberance. Key opinion leaders went on record saying that nearly all patients with low EF should have an ICD. Really, they said this. I have receipts. The device companies then gave weekend courses to non-EP docs to get them qualified to implant ICDs, because the key opinion leaders said there would be not enough EPs to install all of these devices. And of course, the Heart Rhythm Society allowed all this. And I'm sure that the HRS funding from industry had no influence in letting this happen to its members. That policy of having non-EPs implant ICDs, especially through weekend courses, has now been reversed, and only EP docs get credentialed to implant ICDs. But it took many, many years. Cynicism aside, the primary prevention ICD trials were positive. There were statistically significant reductions in death in these young, mostly male patients with low comorbidity that were recruited from outpatient heart failure clinics. The major problem I had and have with ICD use is translation of this data to these less robust, older, and frailer patients with heart failure who have competing causes of death. Remember, an ICD is only beneficial as a prevention of sudden cardiac death. If you have other ways that are threatening your mortality, then an ICD is likely not to benefit. Now, times have surely changed since these things came out around the turn of the century. In 2017, heart failure trialists have published a remarkable paper in New England Journal of Medicine that I will cite, and it shows that sudden death rates in heart failure trials have declined substantially over the years. They reported a 44% decline in the rate of sudden death across trials that was statistically significant. The cumulative incidence of sudden death at 90 days after randomization in heart failure trials was 2.4% in the earliest trial and 1.0% in the most recent trial. That is, in trials, what about real-world data? And this is why I highlight the Danish study, which used the incredibly valuable Danish National Registry. So this is what the study looked like that was published in JICE. This group in Denmark looked at ICDs implanted from 2010 to 2020 at the big hospital in Copenhagen that I cannot pronounce, called Rigshospitalet. It's a huge referral hospital. Their primary outcome of interest was incident shock combined. That is, patients who had first appropriate and first inappropriate shocks. But they also looked at first appropriate shock and first inappropriate shocks that considered separately, and in patients who had one shock, the recurrent outcomes were also examined. They had a group of about 3,000 patients over the 10-year period who received ICDs and who were chronicled in the Danish registry. The mean age of these patients was 62. Let me repeat, mean age 62, not 82 or 75 or 85, 62. 80% of these patients were male and their follow-up was good at 4 years. All total, 14% of patients had a shock. Now this included primary and secondary prevention. 12% appropriate shocks, 2.7 inappropriate shocks. This annualized event rates that was about 2.34 and 0.49 per 100 person years respectively. Of those with a shock, 36% experienced a recurrent appropriate shock. So patients who get a shock are at very high risk of getting another shock. We sort of know that. The authors presented a lot of other interesting data beyond the main findings in the abstract. First, the 5-year cumulative risk of shock in the primary prevention cohort was 6.7% versus 15% in the secondary prevention cohort. And that we sort of get, right? Because secondary prevention, the patients already had VT. Annualized, that comes out to 1.5 per 100 patient years in the primary prevention and 3.2 per 100 patient years in the secondary prevention cohort. This is substantially lower than in the seminal trials. For instance, I went back and looked at SCUD-HEFT. 31% of patients in the ICD arm in SCUD-HEFT received a shock. 21% received an appropriate shock. So that is 6.7% versus 31% difference. That's a big difference. Importantly, and similar to the trial data that the heart failure trialists have published in 2017, shock event rates have declined over time in this Danish registry. Comparing those implanted before and after 2015, so they had 5 years, 2010 to 2015, and then 2015 to 2020, they found that the hazard ratio for shock in the second 5-year period was 0.58, and it was 0.55 or 45% fewer for appropriate shocks. The Danes also got much better at preventing inappropriate shocks in the second 5-year period. Here they showed that there was 62% fewer inappropriate shocks in the second 5-year period. Now, in addition to inappropriate shocks, they also noted the rate of complications. That includes infection and lead issues were the major ones. They then combined inappropriate shocks and lead complications to get a number needed to harm, or an absolute risk increase. They then did a NNT, number needed to treat, absolute risk reduction, and NNH, absolute risk increase comparison. Now, using appropriate shocks as a surrogate, as an NNT, it's not a perfect surrogate for mortality because not all appropriate shocks are life-saving, but in any event, they came up with an NNT for a shock. The NNT for implantation before 2015 was really low at 8, but it doubled to 15 after 2015. So the absolute risk reduction became less over time due to less VTVF. But the number needed to harm, including all complications, not just inappropriate shocks, was 10 before and after 2015. Now think about that for a second. Over time, this analysis found a decreasing absolute risk reduction, absolute decrease in benefit in appropriate shocks, but sort of a stable degree of harm. That led to the finding that in the second time period, the absolute risk reduction was actually less than the absolute risk increase in harm. In multivariable analysis, they found that female sex was associated with the reduced risk of appropriate shock. The hazard ratio here was 0.69, but they found really no other obvious factors that stood out as predictors. So my comments in summary: inappropriate shocks are way down, and that's a very good thing. Programming has improved, and this remains a crucial part of ICD use. We do these timeouts before surgeries, but I think we should do a timeout for programming at the end of each case. The most important thing with this paper, though, is that real-world data shows that the rates of appropriate shocks are way less than in the seminal trials, and that they're decreasing over time. As the ICD absolute risk reduction becomes less, and the number needed to harm or the absolute risk increase remains stable, this makes a suggestion, at least from observational data, that the overall benefit-harm balance from the ICD, especially in the primary patient cohort, is in doubt. So I am very happy that European investigators, brave European investigators, are randomizing patients in the PROFID trial, which will basically try to replicate MADE-2, which is ICD versus medical therapy in patients with a ischemic cardiomyopathy. Danish investigators in the Danish trial have already shown that the ICD does not improve mortality in heart failure patients with non-ischemic cardiomyopathy. Now, this paper also finds that there are few predictors of who will benefit from the ICD. And I have to tell you, that's been a decades-long mystery. You just don't know who is going to get an appropriate shock and who isn't. Most patients who get a device never use it, but some do. Primary prevention with an ICD is similar to all of primary prevention. It is hard. Again, I close with a statement that we excel much more in medicine at treating people with problems rather than treating people who have yet to have a problem. Okay, that's it for this week in cardiology. Remember, next week is the week before ESC. I will have an ESC preview coming out in written form next week. And then, of course, in coming podcasts, we'll have many trials to review from the ESC. I will do the ESC review from home, as this is the first time in about 10 years that I haven't attended ESC, but I'm doing so much travel and need to have some balance in my life. So that's it for this week. As always, I'm grateful that you listen. Thank you. And remember, if you like this podcast, please take the time, give us a rating, write us a review. If you disagree with something I say, go to the website, write a comment. I always learn from these. Until next week, an ESC, this is John Mandrola from the heart.org, Medscape Cardiology.
You're listening to This Week in Cardiology from the heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.